Here today to talk about diabetes reversal, whether it is a myth or not. Today, alongside me, I have Dr. Pooja. She's my colleague, another endocrinologist. She also works with me at Tata MD at Whitefield. Together, we hope to shed some light on this complex topic. There's just too much going on around this topic, and the waters are very muddied. And I'm sure a lot of you all are looking to get some clarity on this scenario. So welcome you all. Thank you for having taken out the time on a Sunday evening to attend this talk or webinar. I will set some ground rules first. So the first thing is that whatever we're talking about today, this refers to only type 2 diabetes. Reversal, remission, etc. These things do not apply to type 1 diabetes or if you have secondary diabetes. If you're not aware as to which type of diabetes you have, please do speak to your healthcare provider or your doctor. They will be the best people to guide you. Do not try anything without this clarity in mind. So let's get started. So first things first, we need to understand what we're talking about. Otherwise, at the end of the meeting, we'll all be discussing as to what happened there. So we don't want that kind of a scenario. So first, let's clear some terminologies out. So the two terminologies that we want you to understand the difference between is reversal and remission. So I'd ask Dr. Pooja to explain to us about the difference and why this difference or the differentiation is important.
So reversal means the disease has gone forever. So in what happens in diabetes is we prefer to say the word remission. Remission means the HbA1c is less than 6.5 for more than 3 months without any help of any medications. But still, there is chances that if you miss on diet or exercise or any lifestyle changes can bring back diabetes again. So I'll just explain it to you in an easy terms if the fire is put off and the ashes are still there and some risk factors like if you throw dry leaves on it and the fire can catch up again. So that's how remission is. So remission is a better word for diabetes being normal under control, and it's a journey, I must say. So it's remission is
That's
better.
Right. That's right, Dr. Pooja. So this is something that needs to be very clear in your minds. The term reversal is so misleading. It often gives you a sense of finality that I have achieved this and as in I've arrived at a destination. But remission is always a journey. And as Dr. Pooja said, things do flare up very quickly. So we have had instances of people who've been off medications for 3 years, 4 years, 5 years, and then something happens where they're not able to maintain their remission and their sugars come back with a vengeance. So this is something that you need to remember. It's a continuing journey that one has to persist with a good diet, exercise, etc. So henceforth, we'll be referring to it as remission. Some people do use reversal and remission as interchangeable terms, but this is the basic difference. Remission is certainly possible, and we should be trying to achieve that. This slide is actually a gem of a slide. I'm not sure who designed this. This is a beautiful slide which encapsulates everything that goes wrong in type 2 diabetes and why type 2 diabetes is so dangerous and very difficult to comprehend and take care of. Dr. Pooja, would you like to take us through this slide?
Yeah. Diabetes starts before you're diagnosed with diabetes. Few years before only it starts off with insulin resistance. So what is this insulin resistance? Basically, your body is producing excess of insulin, and that is not why, because it's not able to act properly. The insulin which is produced is not able to act properly and bring down the sugar. So this is known as insulin resistance, and that excess sugars gets converted into lipids, and this lipids gets deposited in the liver, the pancreas, and the visceral organs, as well as your belly fat. So these are the risk factors which over a period of time goes on and you develop diabetes. So that's how the iceberg part is, as shown in the figure, tells us that long before you're detected with diabetes, your body is struggling and making up for the excessive sugars which is being produced in the body.
That's right. So this is the primary problem. So the body is actually designed with a lot of resilience and a lot of spare capacity. This ideally should be a blessing, but unfortunately, in this scenario, at least, it turns out to be a curse because people don't understand what is happening until the situation is quite bad. So when you're insulin resistant, you don't realize it. Your body is able to cope by making more and more insulin, so you don't realize it. But the body does throw out subtle hints. So it gives you the fatty liver because all the sugar is getting converted to fat, and your liver is full of fat. Because your liver is full of fat, now it starts making more cholesterol. So then your cholesterol starts going up. You start developing some darkening around the neck area. Things it's called acanthosis. All these things happen. All these markers are there, but unfortunately, these are often missed. People nowadays do a lot of health checks, and all these things are already highlighted there, but it's often just not picked up. I'm sure Dr. Pooja's experience will be similar here.
Yes, yes, there are a lot of patients who come with pre-diabetes or diabetes where 3 to 4 years back or 1 year back they have done a health check where the excess cholesterol or the fatty liver or the borderline sugars have been missed out or have been not picked up. Is it like if we pick up those things at an early stage, maybe we can reverse remission is much easier and more faster also.
That's right. So the earlier you pick up, the less the damage that has happened to your body. The less the damage, the better or the quicker and easier it is to fix the problem. So this is a very important figure to understand the complexities of diabetes and why we insist on early diagnosis and early treatment. Now, the next question is, can I achieve remission? How do I know that? So on what basis do we say remission is possible? Who are the ones we should be targeting for remission? Dr. Pooja.
So it's not hard and fast rule, but it's remission is mostly possible in people who are young and who the duration of diabetes is less than 6 years, or early diagnosis can go into remission faster. And if you lose a significant amount of weight, that is 10 to 15% of your initial body weight, and if you have adequate insulin reserve, the beta cell reserve, or the pancreatic reserve, such patients can go into remission earlier and faster also.
Yeah. So absolutely right. So it doesn't mean that if you have diabetes more than 6 years, then you're not able to achieve remission. You can certainly try. It's just the probabilities. So the probability of achieving remission is much better if you're younger, if you've got a shorter duration of diabetes, and if you're overweight and you have a large amount of weight that you're able to generate. Another key point is that the pancreas should still be capable of generating insulin. We often use a test called C-Peptide. So this tells us or gives us an idea of how much insulin production reserve the body has. So the higher the C-Peptide, better your chances. So we can often use this to stratify your probability of remission. But it's not always about remission, is it, Dr. Pooja? So even if you're not able to achieve remission, it still has benefits.
Yeah, because even though after 10 years or 15 years of diabetes, if you keep the sugars under control, so this has better benefits, mainly in the term of complications. So the complications are less, so less development of neuropathy, retinopathy, the cardiac complications, the renal complications. So all this reduces with good control of sugar. So if you have diabetes of 10 to 15 years, you're not so it doesn't mean that you're not going to a point, so you just leave it off and I can't achieve remission like that. But good control of sugars is always good. There is something called glycemic memory, where the body or the cell remembers how you have been treated, like that. So good maintenance of sugars is always good.
That's right. So as we discussed earlier, this is an ongoing journey. I think the just like how we aim for perfection, the aim is remission. Or a better way of looking at it is the aim should be that the sugar should be well controlled and you should avoid complications. Now, when you're working towards that, if you're able to achieve that aim without medications and you're able to achieve remission, then well and good. But even otherwise, if you are able to reduce your medicine requirements or on medicines, you're able to achieve an A1C of less than 6.5 and keep it well controlled. you still have other benefits in terms of the cardiovascular risk. So your risk of heart attack, strokes, etc., all of those go down dramatically when your sugars are well under control. So don't be disheartened if you think that I've had sugars for 15, 20 years. So this is not applicable to me. While you may not be able to achieve remission as often as people with a shorter duration, so it is still possible. I don't say it is impossible. I just say it is less probable. So even though you will not be able to achieve complete remission, the fact that you're able to work hard towards it and keep the sugars under control with less and less medicine, that does pay dividends. So how do we go about achieving remission? So the 4 pillars that we refer to, they all contribute towards remission. And this is just like how diabetes is a multifactorial condition, sorting it out also takes multiple courses of action. So first and foremost is diet, followed by physical activity, stress and sleep management, and of course, medication support as well. I always like to look at it as a chair with 4 legs. You can't expect it to stand on 3 legs. So you do have to work on all 4 aspects to achieve your results. So would like to go through these aspects in a bit more detail. So Dr. Pooja, would you like to talk us through this plate?
Coming to the diet, so the simple and the most effective part is the plate method. So half of your plate should always be filled with veggies. So it can be raw vegetables or cooked veggies also in the form of sabzi. So this portion of the food gives you the fiber part. So how the fiber is helpful is the fiber keeps your stomach full also, and will also prevent the sugars from spiking up. So the next quarter of the plate should be protein. Protein is like the muscle building when you are exercising, when you're on this diet. So this helps build muscle also, and it also keeps the hunger pangs lesser. So protein must be included. So animal part of the protein, you can include chicken and fish, and avoid red meat. And the vegetable sources like dal, paneer, legumes also can be included. So the next quarter should be carbs. Carbs, the rice and the ragi comes with the highest glycemic index, and next in the strata comes the oats, millets, and which have a lesser wheat, which have a lesser glycemic index, and that might be preferred more. So this is how your plate should look at breakfast, lunch, and dinner. And we prefer having dinner by 8 p.m. so that whatever after 8 p.m. you eat gets converted into fat or cholesterol. So this is how you maintain your diet with a healthy, simple way, the plate method.
Yeah. So this is a very simple sort of method that has been developed to convey to people, because often dietetics can get a little too precarious with so many grams of this, so many grams of that, and so on and so forth. So we don't expect you to weigh the foods, etc. But generally, if as a visual guide, if you can use this plate, it makes a huge difference. That 50% veggies, 1/4 carbs, preferably complex carbs, and 1/4 of protein. Keep it simple, keep it consistent. It pays dividends. Also, the quality of food is important, and as also Dr. Pooja mentioned, finishing your dinner is extremely important as well. Finishing your dinner early, rather. Rest and resilience, stress management, and sleep. I alluded to this earlier as well. So this is a very important component. Sleep can have horrible consequences for your hormones. Isn't that right, Dr. Pooja?
Yeah, especially the 10 p.m. to 7 a.m. sleep is very important, the night sleep, where your hormones are actively being produced. And most of the time, we have seen that the metabolic syndrome is more in people who don't have good sleep or who are night shift workers. And the quality and quantity of sleep both are important. So avoid screen time after 7 p.m. and avoid caffeine and heavy meals before bed. So all these helps you improve your sleep hygiene, so that people think that sleep is one of the last thing to think about. I would say sleep and stress is the first thing to think about. When coming to stress increases your cortisol, which increases your visceral fat. Visceral fat is the belly fat, the fat around your organs. So that increases your insulin resistance. So that's how important stress is. So do regular breathing exercises, yoga, meditation, and whatever helps you to reduce the stress. So stress and sleep, I would say you should somehow manage it to keep it perfect.
And often the stress management it becomes very difficult for busy
Lokesh,
professionals. It
కొద్దిగా
becomes,
మొబైల్
it becomes very difficult for working professionals in today's context. So we often miss out on taking breaks for ourselves, taking some time off to look after ourselves. So that's very important. Work from home is another issue that I'm sure Dr. Pooja as well would have come across. Often there is no separation between work and home life, and this means that the stress of the work is carried over into the latter part of the day, and then it then disturbs your sleep as well and all of that. So it's important to take a break. Quite often we suggest to patients that so after work, you do something that you like doing, a hobby or some sort of relaxation, maybe exercise, maybe yoga, maybe meditation, maybe play a sport, maybe whatever hobby you have. Try and spend a little bit of time to give that little break from your professional work and your homework. That makes a big difference. This is a further additional challenge, particularly when it comes to women, because that separation is often not there. So they have to pay extra attention on this front. But you need to prioritize your health, your rest, your emotional well-being. All of these things you have to prioritize and find time for it. Exercise is the third pillar, very critical pillar. But the nature of exercise, the type of exercise also has a huge impact on the results. Dr. Pooja?
Yeah, so we actually advise exercise like 150 minutes per week, and which is divided into like 45 minutes per day, and include more of aerobic as well as the resistant training exercises where it helps you build muscle. So why we are stressing on the resistant training is that these when you build muscle is when your sugar spikes, or when these muscles help in control of the sugar level. So they will and also your basal metabolic rate increases with building up muscle, and that's when whatever fat you have lost, if you regain it back with muscle, so that's when your sugars are always kept at check, and whenever there is excess sugar, it gets used up by these muscle. So the basal metabolic rate also improves, and that's how both aerobic as well as resistant training has to be included. And there is no like excuse on these exercises. So even if you can't do it one day, make sure that at least 150 minutes is done for a week. And like we already said before, that these are all the pillars of good lifestyle and not getting metabolic diseases at an early age. So exercise is one of the things which you can do it in the morning, if you have time in the evening, so anytime throughout the day include it. That's what I would
That's
like to say.
That's right. So, as Dr. Pooja alluded to, so the timing when it is done is not very important. People often get hung up on I'm busy in the morning, so I'm not able to exercise. So that when you do the exercise doesn't really matter. At some point, it has to be done. And as Dr. Pooja mentioned, that you need aerobic stuff, but you also need strength training. The strength training is very important because the nature of our lifestyle is such that we don't really tax our muscles. And if you don't make your muscles work, you're going to lose them. That's just the name of the game. As you age, again, the tendency is that people tend to lose muscle. So you have to overcome this, because every time you lose muscle, your insulin resistance is getting worse. So to improve your insulin resistance, you need to build muscle. And that is why the insistence on resistance training. Another common issue that we come across is that, but I have knee problems, so I cannot do this exercise. I have back problems, so I cannot do this exercise. I cannot lift weights and things like that. See, resistance training doesn't always have to be strength training, as in weightlifting. So it can be done in many ways. So if you have knee issues, try and get into the water. That helps. Swimming is a very good way of strength training. It's a combination of both aerobic and resistance training. People who have joint issues or significant weight issues, they do very well on that. If you have lower body issues, you can do upper body exercises. You can do resistance bands. So there are a whole host of options. So you need to find that form of strength training which works for you. Now, for that, I think you should get a little bit of professional guidance. Speak to a physical trainer or a physiotherapist. Let them do an assessment on you. They can figure out what you're capable of doing, and then they can advise you on the appropriate exercises. The worst thing you can do is try and do something that you're not capable of, or that you're not properly trained at, and then you end up injuring yourself. So you just, because every injury will set you back a few months. So you just need to be cautious and don't be over exuberant about it. So take your time, do it under professional guidance, but you have to have some strength training there. The last pillar, of course, is medications and medical guidance. This is extremely important, and we often come across a lot of reluctance with regards to medication. So whenever we suggest somebody's HbA1c is 8.5, 9.5, 10.5, and we suggest to them that you need to do your diet, you need to do your exercise, you need to take your medications, we meet a lot of resistance on this. There's also a lot of misinformation that's floating around saying that if you take medicines, you're stuck on it for the rest of your life. So don't take medicines. If you take your medicines, it'll hurt your kidneys. Those are discussions for another day. But the medications, those are myths. But we'll discuss that on another day. But the nature of the medicines that you take makes a big difference. So that's why you should speak to a properly trained professional and get their advice. So a lot of our medications are actually designed to reduce insulin resistance. There are a lot of medications that actually help with weight loss as well. People who have pre-diabetes would have, I'm sure this will be familiar to them. They put in a lot of effort in terms of diet and exercise, and still they don't see much results. This is because of the insulin resistance putting you in a bit of a loop wherein the high insulin resistance is causing a lot of fat deposition, like Dr. Pooja mentioned earlier, which then makes you more insulin resistant, and then you just go in a loop and you continue to put on weight. Or even if you struggle and lose a little bit of weight, you tend to put on weight very quickly. So the choice of medicines makes a big difference. There are medications such as the GLP-1 agonists, which can be used for extremely overweight patients to try and control their weight, get their weight down, and help them get started on the journey. As the weight comes down, then they're able to do a lot more, and they can fend for themselves. In any case, the medications are not to the exclusion of diet and exercise. The foundation of therapy is also is always diet and exercise, and the medicines are added on to get you to your targets. So it's important that you take the medicines, follow the diet, follow the exercise, and track your A1C and sugars regularly. And as the sugars come down, you'll find that your doctors will gradually cut down your medications and they will be able to withdraw it. So if your HbA1c is 6.5, fair enough. Diet, exercise, you can try on your own. If your HbA1c is 10.5, please don't try doing it without medications. You can end up with multiple issues and you're more likely to fail. So do take the assistance of medications. You can still track your journey towards remission, but medications are a pillar of the journey. So do discuss it with your healthcare provider. Yeah. So we'll end here. I'd be happy to take questions. If you have, both me and Dr. Pooja would be happy to take questions. If you have any questions, do put it in your in the chat box. We'll pick it up from there.
Can we ask questions directly on the call, or do we have to?
Sure. Yeah.
Dr. Fred, my name is Anand. I'm 50 plus. I have come to you before for my diabetics medicine.
Right. Okay.
At that point, my HbA1c was 7.9, right? And 6 months later, it's about 6.5. Okay. So I have two questions. One is, as since it's around 6.5, does it make is it possible to reduce the medicine, because the medicines you have given are working fantastically, right? Keeping my sugar levels well in control, right? So is it possible to or do I need to come to check if I need to reduce my medicines further on?
Yeah,
simply because the medicines are working well.
Yeah. So see, knowing, I mean, if I've seen you, I can imagine what be on my prescription. So typically, I tend to use a lot of these drugs, which can actually help you with weight loss. So you may have lost a little bit of weight. You might have noticed that your belt size would have gone down. So you would have lost a little bit of abdominal fat as well. So your belt size might have gone down. So with these kind of medicines, what we tend to do is every 3-4 months, as your sugar comes under control, we tend to cut down your medications further. We cannot take it all off in one go, but we gradually drop the dose. The reason for that is the way these medicines work. If you don't mind, can you just mention what are the medicines I've given you?
Oxramet S XR
Yeah. So the
500 and the Cetafin XR 1 gram.
Yeah, so the oxymet is what we're discussing about. So there's something like dapagliflozin, for example, that is the composition. So the way these medicines work is it's an overflow system. So as soon as your sugar crosses the 130, 140 mark, that's when the sugar, the excess sugar gets thrown out into the urine, and that causes weight loss or fat loss. And then when you lose fat, then your sugar comes back down normally. So if you continue with the same medicines, while the sugars will be well under control, you do not get the USP of the drug. So that is why we typically call you every 3 months and then we just cut down. So your sugars, A1C is 6.5, we'll cut down the medicine. So when we cut down the medicine, initially we expect it to go a little higher, but then this gets dumped out. You maintain a good diet and exercise, and you'll find that in 2-3 months when you come back, your A1C is again 6.5. And then we can cut down again. So that's how we need to take it.
Okay. So then you kind of led to the second question, which is how often do you need to check your HbA1c, which is you said 3 months, right?
3 months, yes, that's right. So 3 monthly is what we advise, because usually by 3 months we expect that you'll with the cut down you would expect it to be back to where we started, and then we cut down further. So this is all predicated on the belief that the diet and exercise are spot on.
Okay. Does it other than HbA1c having a automatic glucose monitor or regularly checking by yourself? Is that also does it also help to get an idea about where you are?
Yes, it does. So see, with every test, the you should have a question. Okay. And if I have a question and I need an answer, then you do a test. So if you're doing the glucose monitoring, what is your question? If the question is, do I need to change my medicines? Do I need to adjust my medicines? Then you need to be doing frequently. So in your case, for example, that is not the case. We're not going to be changing the tablets every other day. So you don't need continuous regular monitoring. What you need is intermittent monitoring, because the question you are asking is my sugar under control? So you don't want to go 3 months, 6 months, and your sugars are out of control and you don't realize it. That should not happen. So for somebody like you, once a week or once a fortnight is more than enough. It's just to make sure, okay, everything's okay, that's fine. Now, coming to your question about CGM, it's actually a very useful learning tool. See, quite often we don't understand what is in our diet and where we are going wrong in our diet. We all think that, okay, I'm eating only 2 chapatis, I'm only eating this, I'm only eating that. I don't have anything, and still my sugar is going high on all of that. Once you apply CGM, and you see that real-time feedback, that when I have my filter coffee, what's happening to my sugar? When I have my cappuccino, what is happening to my sugar? When I have that small little pastry, what happens to my sugar? You get a good feel for how your body reacts to different foods. And then the sensor typically lasts for about 14 days. So that gives you enough time to experiment and find out where you're going wrong, which things work for you, which things don't work for you, and then you can work on those. So CGM has a place, not as a continuous thing, but just maybe as a learning episode for 2 weeks or so, or maybe 4 weeks. You can use that. Monitoring intermittently, weekly once or fortnightly once is enough. Again, this varies from person to person. I'm talking about your current scenario where you're well controlled. And once in 3 months, you should get your A1C and get your medicines adjusted.
Okay. There are a lot of diabetic reversal programs in the market. Does
Mhm.
it make sense to follow that, or just blindly do this once in 3 months is good enough?
Yeah, so see, it's essentially see, what we're doing is the same thing. I mean, if you come to the clinic, I can show you instances of people who have come off medicines. So you've stayed on the same medicines for a long time. If you had cut down at times, at the appropriate times, you might have been on a lot less by now, or maybe you might have even stopped. But the difference is that we don't call it reversal as such, because of the reasons detailed in the talk, because it never
Right.
really goes away. Okay, so I mean, very simple way of looking at it is, a normal person Their capacity is huge, demand is very less. By the time you come to a diagnosis of diabetes, your capacity is already down to 40-50%. Your demand is way high. You've now, with diet, exercise, medicine, weight loss, you're able to bring down your demand. But as you age, your capacity will only go down. Your capacity is not going to go back up. So that's why you should always consider yourself as a diabetic under control, even if you're not on medicines, and under control on diet and exercise. Again, I often tell people to think that, just think of diet as your first medication, exercise as your second medicine, and whatever I've prescribed as your third medicine. So you may come to a point where 1 and 2 are enough and 3 is not needed, but that doesn't mean that the problem has gone away.
Okay. Is there any program at Tata MD which helps with this, or do you recommend I just come and visit you and then see where I am and then go for there?
Yeah, so I mean, we do all the same things. We have the dietetic support, we have the CGM monitoring. It's just that we function as a clinical place and not as a marketing tool. That's all. But we do the same things, okay,
Thank
in
you,
a more
doctor.
justifiable way.
Yeah, sure. Thank you.
Hello, Dr. Fred. Couple of questions from my side. This is Prem.
Hi.
You remember me?
Yes.
Yeah. The first question is, we keep monitoring at home, maybe alter every 15 days. So when we are monitoring at home, there are three parameters we can monitor at home. One is fasting. The second one is PPBS. The third one is random. So out of all the three, what is most important? Are all three important, or is it anything out of three which is very specific is important?
Okay, so I wouldn't worry too much about the random. See, the random is, just as the name suggests, very random. It can be a one-off. So even somebody who has sugars 400 all day will have at some point will have a reading of 180, which looks decent. So the random doesn't really give you much info. Fasting and postprandial both are important. Yeah, and both are equally important. Both need to be kept under control. And when you monitor, it's important to check both, because there can often be a disconnect between the two. So you can have a fasting sugar of 100 and your PPBS can be 250. You can have a fasting sugar of 100 and your PPBS might be 120. Or vice versa, you can have a fasting of 150 and your PPBS is 160. These kind of disconnects happen. The insulin secretion mechanisms, etc., for these things, for both of these things, are slightly different, which is why you tend to see this disconnect. So it's important to check both.
Okay. The second question is, there are so many, confusion going on in the market when it comes to the numbers. I mean, when I say numbers, 110 for fasting and up to 140 is for PPBS, the range.
Yeah.
But there are many places where it says even 180 is it's fine, it is normal. So it's a real confusion. So what exactly it has to be?
Okay. See, you need to verify your sources. Okay. There are a lot of people out there whose only point in life is to spread misinformation. Okay. So first thing is, there has been no issues in terms of diagnostic criteria. So 126 plus has been diabetes forever, fasting, and 200 plus has been diabetes forever,
Okay.
from the beginning. The only area of confusion is what is pre-diabetes. Okay. So if you look at the ADA guidelines, which is the American guidelines, so less than 100 fasting is normal, 100 plus is pre-diabetes, 126 plus is diabetes. Okay. If you look at the WHO guidelines, up to 110 is normal, 110 to 126 is, or 25 is pre-diabetes, and 126 onwards is diabetes. That is the only place where there is a issue, where there is a mismatch and there is a bit of confusion. Okay. Now, coming to the question of 180 is okay, 200 is okay. So we showed you that image of the iceberg, right?
Yes.
That is the thing. So when you're 180, okay, you're pre-diabetic, that is not okay, because if you leave it at that point, it is going to progress. Again, a very common analogy that I use, my patients would have heard it from me all the time. You might be floating in the water with your nostrils out. You might be breathing, but that's not going to stay there forever. Okay, that's not a sustainable scenario. Also, you need to understand the concept of pre-diabetes. Okay, so it's not a linear stepwise thing that you're normal and then you become pre-diabetic and then you're not pre-diabetic for a while and you become no. It is a continuum, and we have drawn two lines to say that okay, below this you're normal, above this you're pre-diabetes, above this you're diabetes. The reason those lines are there are statistics. So, very simple terms, if you take 100 people who have a HbA1c of less than 5.7 and you follow them up for 5 years, only 10 or 15 will become diabetic. Okay. If you take 100 people whose HbA1c is 5.7 to 6.4, okay, almost 50 to 60 of them will become diabetic in the next 5 years. That is the reason that window is called as pre-diabetes.
Okay.
You will find somebody who's there who doesn't progress to diabetes in 5 years. It might happen in 10 years, but the probability is much higher than somebody who's below that. Why the HbA1c of 6.5 is considered as diabetes, or a fasting of 126 and ppbs of 200 is considered diabetes, is because if you chart out the risk of developing a complication, diabetes complication, against the blood sugars, you see that there is a gradual rise as the sugar rises, but once you hit this mark, your risk actually rises much sharper. So that is the reason that line is there, saying that above this line you are diabetic.
Okay.
And that is the reason, even though we say, less than 140 is normal, when you're diabetic, we're not trying to get you to 130. So if your blood sugars are 140 to 160, we're okay, because we know that the complication risk goes above, increases only when you cross the 7 mark. Okay. So if we can keep your A1C under 7, then we are minimizing your risk of developing a complication. So that's why.
Okay. Two more questions, if you allow me, in the interest of everybody. Like we see random HbA1c every 3 months. What is the best numbers we get? Is it HbA1c or fructosamine?
So that depends on, for the vast majority of the Indian population, HbA1c is adequate.
Okay.
But the HbA1c does have some weak points. So, for example, if you're severely anemic, or if you're thalassemic, so this thalassemia is very common in the eastern parts. So things like Bihar, Jharkhand, Orissa, Bengal, these areas. It's very common in these areas. So in these sort of scenarios, the HbA1c is not reliable. Okay. So because of that, we tend to use fructosamine. Okay. So the go-to standard is HbA1c. If there is a problem with HbA1c, only then we consider fructosamine. Because, well, fructosamine can give you an average. It is basically going to give you an average of 2 to 3 weeks. So when we don't have the option of using HbA1c, only then we go to the fructosamine.
Okay. So last question. So as I remember that you had recommended CGM for me. So this is only for a short duration, right? Like you mentioned, 2 weeks or 4 weeks, to understand how my body is reacting to different types of food.
That's right.
And when we do this CGM, based on that, you change the medication. Is it something like that?
Yeah. So there is intervention. So now that intervention may be in the form of diet, in the form of medications. So both run parallelly. So for example, so when we do the CGM, we normally tie you with a dietitian. So we expect you to keep track of your food intake as well. So you can see it yourself as well. And the dietitian will guide you. Okay, so you had this as a meal. So this component was wrong. So you had too much carbs. So cut down this carbs, try this, try that. So you make changes on your diet, or maybe walk 15 minutes after the meal, or maybe try and take the salads first and then have your main meal, so that the absorption of the sugar is slower. So depending on the patterns that we see, first is dietary intervention. If we find that no, the sugars are going very high, dietary intervention is not enough, or we do the dietary intervention and still the sugars are going high, then the next step is medication intervention.
Okay, fine. Thank you very much. All my questions answered.
Thank you.
Hello, doctor. This is Akila here.
Hello.
Doctor, is there any different approach for ladies who are postmenopausal, who have this hormonal issues and weight gain and cortisol level also high? So do you really take into consideration the cortisol for weight loss? Because whenever I come to visit, you always insist on weight loss.
Yeah. So the cortisol is a hormone which can make it difficult for you to lose weight, but only if it is in excess of requirement and is being produced inappropriately. Okay. So if it is being produced inappropriately high, so like for example, let's say you have a tumor in the adrenal gland which is producing cortisol, then whatever you do, you'll not be able to lose weight. So then you need to treat that. Now, if your cortisol is just slightly high, but it is an appropriate response, what it means is it is a response to stress, which means that there is a stress issue. Okay, so if you're somebody who's under a lot of stress, then you'll typically manifest by having slightly high cortisol levels. So addressing the stress is the way to go about. It doesn't need any separate medication as such. Now, to address the stress, that might be things like meditation, or it might be medications, or it might be resolving whatever issue that is going on. So those things have to be taken care of. Post-menopause, again, an additional challenge that we face in women is bone density issues, and also women generally tend to carry less muscle. So again, strength training is one thing which particularly Indian women often struggle to accept. So if you can get into a little bit of strength training, often people just assume that strength training is just going to the gym and heavy duty bodybuilding. That's not the case. I think that is a misconception that we need to expel. So doing light things at home with a stress resistance bands, or with therabands, these kind of things, that makes a huge difference to a woman's health. And strength training also helps with the bone density. So it's not just the weight, the osteoporosis risk also goes down. Isn't that right, Dr. Pooja?
Yeah. So that's what we always suggest in case the strength training basically to include, because postmenopausal you tend to lose most of the muscle because of decreased estrogen. So better you build your muscle up by doing strength training exercises. And in case even after giving 6 months of it and you're not able to do it, you can take help of little bit medications also to lose that initial 10 to 15 kgs, so that your basal metabolic rate improves better. And that's how the overall thing you have to think about. And you can't, it can't be like fast forwarded, or you can't do it in just 3 months. It will be like you just give it time, 3 6 months, 1 year. Over a year, 10 to 15 kgs weight loss will help you a lot, and building muscle also.
Yeah, and that's the thing. There's often a hesitation to accept medications. See, you have to accept that the way diabetes works, the way insulin resistance works, it is very difficult to lose the weight. It is not easy. It's very easy for us to advise, but we acknowledge that it is very difficult to achieve. The physiology is built like that. There is a loop that you're in, and you find it very difficult to get out of. So taking the help of medicines to break that cycle is not something that you should be worried about.
Thank you, doctor.
Oh.
Any other questions?
Yeah, sorry, again, I have one more question.
Sure.
But it's a very, very strange question, but I have to ask.
Sure.
I have been reading so many articles for last couple of weeks or months. What I read is they say sugar has nothing to do with the diabetic patients. You can eat, there is no problem. What's your comment on that?
No, that's just not right. See, it is just wrong on so many fronts. Okay, so okay. So while sugar, when you refer to sugar, if you're referring to just a spoon of sugar in the salt in your coffee, tea, yeah, that's not the reason why you become diabetic. Okay, see, what you see in sound bites like this is really oversimplification. Okay, if you're referring to just you don't get diabetes because I have a spoon of sugar in my coffee, that is true. That's not the cause. The most important cause for diabetes, certainly in the Indian or subcontinent context, is that we are a carb-heavy nation. So we tend to consume just too many carbs. So I mean, if you look at the diet as well, so I'm mentioning millets. Millets is a good option. But then North Karnataka, people just eat millets, but still they have diabetes. Why is that? Because they tend to be carb heavy. The North Indians think that eating ragi is good for diabetes. The South Indians think that eating chapati is good for diabetes. At the end of the day, everybody has diabetes. Okay, so it's the carbs. The primary understanding that one has to have is it is the carbs which are sugar. And if you have too much carbs, it needs to be a balanced diet. If you have too much carbs, you're going to get diabetes over time. This is compounded by our genetics. So genetics we cannot do anything about. Okay, so if you see Westerners, they don't tend to get as much diabetes as us. So Caucasian population, for example, their rates are 3 to 4%, whereas we official rates are around 11-12%. What we see on the ground is closer to 20%. So the reason for that is our genetics. We tend to hold on to a lot more fat. So for any given weight, we tend to have a lot of abdominal fat. And then when you combine this trait with the tendency for too much carbs, which then get converted to fat, that's what has led to this explosion of diabetes in India. All these things about the sugar is not something that gives you diabetes, or if you take something, a spoonful of something is going to cure diabetes. These are just clickbait. There is no merit to it. You will hear all these things about mangoes. You eat mangoes, you eat natural sugars, nothing will happen. Okay, fine. Today we have processed foods. Diabetes is not a new thing. Diabetes was there in the 30s as well. Of course, in a smaller subset of people, but it was always there. So were they eating processed food? They were eating only natural sugars. How come they had diabetes? But this is oversimplification and just clickbait.
Okay, clear.
Are there any side effects of taking higher diabetic medicines?
Well, that's a very good question you brought about. Okay, so any medication or any foreign substance in your body, there is a potential for side effects. That is definitely there. The potential is there. So if you take a medicine for no reason and you get into trouble, okay, I understand that's not the right thing to do. But when you have a condition where, let's say you have diabetes, I know that if your HbA1c is 8, your 5-year risk of developing eye disease or kidney disease is 15%. Okay. And then I give you a medicine which has a potential for side effect. What is the side effect? It might cause you a little bit of gastritis. And the probability of having gastritis is something like 10 to 12%. But it resolves within a week. Now, is that a fair balance of risk versus benefit? I would say there is no contest. Okay. So that is the kind of side effects that we're talking about. There are minor side effects. There are. If you're referring to this perception in the community that if you take diabetes medicines, my kidney is going to get harmed, my liver is going to get harmed, and so on and so forth, that is just a misconception. Those are the exact complications that we're trying to avoid. Okay. So those are complications of diabetes. So if you, let's say, take medicines, but your sugars are not under control, you are going to get complications. If you have never taken a medicine in your life, you run around with A1C of 10, you are going to get the same complication. It is a complication of uncontrolled sugars. So if your sugars are uncontrolled, every single blood vessel in your body is affected. The sugar actually irritates the blood vessels, causes inflammation around the blood vessel. Over time, that is going to cause a blockage. Then depending on where these blood vessels are blocked, you get your kidney problem, eye problem, liver problem, all those things. Those are what we're trying to avoid. Minor complications, yeah, certain medicines cause UTIs, 3 to 4% risk. Certain medicines cause gastritis. Some people are not able to tolerate. Some people get diarrhea. These are minor things compared to the major things that we're trying to achieve. The reason this focus on side effects and allopathy comes in is because we accept it. Okay. So the nature of the trial process in allopathy is, if a drug comes to the market today, the drug has already gone through 10 years of investigations. And if anybody develops anything during that period, it goes on as a potential side effect. Okay.
Okay.
That's the reason you find that the list is long. But again, if there is a medicine which causes a risk that is disproportionate to the benefit that you gain, we don't use it. It's all about risk versus benefit.
Right. And there are always new medicines that keep coming to the market, right? That's also one of the reasons why you should, even if your diabetes is under check, you should probably visit a doctor to find out whether
That's right.
there are any new medicines that you can probably adopt.
Okay, okay. That's right. So the thing is, so for example, if you see what we studied in medical college versus what is available today, it's night and day. So we never had so many options that were available to us. It's the since the early 2000s is when the complete spectrum has changed. So previously we had only the human insulins. Now we have long-acting insulins. Medications wise, we had only metformin and a couple of sulfonylureas. So very few things we had. But the game has changed so much. There are a lot of medicines. There are medicines now. I mean, you mentioned you're on Oxmet, which is dapagliflozin. Dapagliflozin is now licensed and used by cardiologists in heart failure without diabetes. It's licensed for kidney damage. So nephrologists will use it to prevent progression of kidney damage without diabetes. So if you're a diabetic, you need to be on these medicines because as a diabetic patient, you're at a higher risk of developing these complications. So when you're at risk, it makes sense to be on these medicines.
If your HbA1c is well under control, how often do you recommend that you come and see your doctor for doing some things like this?
Okay, so the normal testing pattern that we suggest is once in 3 months you do your A1C, and then once in a year you do your kidney, your cholesterol, your eye checkup, your foot checkup, all these things, because we want to avoid complications. Again, complications, the symptoms appear very late, so we don't wait for the symptoms. So everything seems like it's going hunky-dory and then everything falls apart. So that's the reason we ask for this. So if somebody is in remission, for example, we still advise once in 3 months checks. You don't necessarily have to come and see us all the time, but so in your case, particularly, for example, we could have been cutting down your medications. So just rest assured that if you don't need to see you, we don't call you. Okay. When we ask you to come back in 3 months for follow-up, that's with the plan.
No, I'm not asking that question. So HbA1c once in 3 months, I understand.
Once in 3 months, yeah.
But my point is, with new drugs coming in all the time, how often is it? Once a year, once in 2 years? If everything is okay, how often should you see your doctor?
Yeah, so new drugs come all the time. So if you're seeing us periodically, if there's some change in the thing, then you will get in touch with us. The periodicity for that purpose is not necessary. If you as part of your routine checkup, if something new has come up to you, something new is
Nothing comes
available.
up. No, nothing. Everything is fine. Then how often do we see you?
Yeah. So at least once in 3 months, do the checks. Once in a year, come and see.
Okay, sure. Thank you.
Yeah, thanks, doctor, for the very informative the session. One question I have is on the side effects. Is it that the insulin has less side effects than the pills?
No, there's again a very common misconception. See, every medicine has a plus and a minus. So for example, insulin, the main benefit of insulin is it's hugely potent. So whether your sugar is 12, 14, 15, 16, it can be brought down. There is no upper limit to the dose, but it does come with consequences. The way it gets rid of sugar is by converting into fat, just like how your own insulin would do. So there is a risk of hypoglycemia or low sugars. So all these things are there. So it is not that if insulin is safer, they're all safe. I'm not saying one is unsafe, one is not unsafe. It is dependent on your requirement. So if your sugars can be under control with one metformin, you really don't need the insulin. Okay. And again, I come back to the same point. What you're referring to as complications, as kidney problem, this, that, and the other, those are complications of uncontrolled diabetes. They are not complications of the medication as such, be it insulin, be it. So, if, for example, if you're taking insulin, but your sugars are not under control, you're going to get the same complications. It has nothing to do with the medicines. It's more to do with the uncontrolled sugars.
Okay, yeah, thanks, doctor.
Anything else? So, Pooja, would you like to sum up what we have discussed today?
Yeah, so I would like everybody to just regularly check your sugars, and every year, at least a health check where you get it through a physician or a doctor, so that, or an endocrinologist, where we pick up subtle things also, and you work towards doing a healthy lifestyle diet, and you keep your health at check. And the second thing is the four pillars, not to forget: the sleep, reducing stress, and diet, and regular exercise. That will always be, even to make it a habit, to make it a lifestyle. So these two things I would pinpoint to carry over from this thing. And about remission and reversal is just a myth, and it is better to call it off remission, is how I would say so.
Okay. Sorry, on the thanks, Pooja. On the chat box, there is a little question that I want to explain the difference between remission and reversal again. So I'll just put that slide up if you want to take me through it. Okay. So I think who was this? Somebody by the name. Okay, don't have a name, but essentially, Dr. Pooja, do you want to take that?
Yeah. So essentially, what is the difference that's between reversal and remission? So reversal means the disease is gone forever. It is something like if you treated an infection and it doesn't come back and it's completely gone, it's like that. But remission is where you have achieved normal sugar levels, but in case if you don't maintain your diet, exercise, you can have diabetes in a later stage. So for an example, to explain it in a very simple way, I was telling it in the initial talk thing. So when there is fire, when you put out fire, so that's when you have achieved normal sugar levels, but still there is some amount of ashes. And if there are risk factors like obesity, again you go back to having unhealthy food or lifestyle changes are there, and you don't have good sleep, and there is increase in stress. It's like throwing dry leaves to the ashes, and the fire can catch up again, so you can go have diabetes. So that's the difference between remission and reversal. And diabetes, by the time you're diagnosed with diabetes, your most of the pancreatic beta cell reserve for producing insulin is burnt out, so it can't go back to normal. So you can keep it under check, you can keep it under control by diet, lifestyle, medications if necessary, but you can't have a complete reversal. That's the difference. I hope the person who asked the question got it. So that's how the difference is. So remission also is a good achievement. I might say it's a good victory. So keeping your sugars under control or keeping it normal without any medicine, keeping your HbA1c less than 6.5 without any medicines is a good achievement. But that has to be consistent. It has to be kept under check, regularly checked, and minor signs have to be picked up earlier, as we were talking, like increase in lipids on your health check or fatty liver. So those are the important things to carry over from this slide.
There's another thing. So for pre-diabetes also, reversal does not happen. Is that the case? I'll take that. So see, I think as I mentioned earlier, this whole process is a continuum. So if you can go towards diabetes, you can come backwards. But if you're not careful, you can get back into pre-diabetes again. So at no point can you say that this is not going to happen again. You have to work on it. Can you keep it in the normal stage for long periods of time, or even for 10 years, 20 years? Yes. So if you're pre-diabetic and you work hard, get some weight off, maintain a good lifestyle, you may be able to manage 10 years, 20 years, 30 years without developing diabetes. But that is because you're constantly putting in the effort. But if you don't put the effort, you start putting on weight, you don't take care of the diet and exercise, then even at the level of pre-diabetes, having gone back to normal, you will come back up, and then you'll progress on from there. Okay, and I think there's also a mention about are we recording the session and can we share the recording? Arjun, you there? That's something that can be done?
I think the session is being recorded, so maybe
yeah.
we
So
can,
we'll put it up on the website. We can send out links certainly for people to look at it.
Right. Yeah.
Okay. Have we missed anything else? I think that's it. There's another question here. What is the effect of alcohol on diabetes? So alcohol has a slightly complex effect. So alcohol is fermented sugar. So it initially you might see a spike, but then later on in the night you're likely to develop a low sugar. So you always have to be a little cautious. Occasional limited alcohol is okay, but it should not be excessive. So that's one thing to remember. Zero alcohol is always better, but yeah, occasional is acceptable. There's another thing from okay, Poonam. Okay, I think we answered that question. Okay. Okay, I think that's it. So hopefully you had a hopefully that cleared some of your doubts and you found it helpful. Okay, there's another thing. However, HbA1c isn't. Yeah, so blood sugars tell you on the day what is the scenario, whereas the HbA1c tells you a more longer term picture of how things have been over the last 2-3 years, 2-3 months rather. Okay, so I think we'll close there. Thank you very much for all those who attended. Hope you found it useful.
Thank you, all of you. Thank you.
Right.
Thank you. అదే దాంట్లోనూ కొంచెం ఎవరికి బాబు రెడ్డికి ఇచ్చి సెటిల్మెంట్ చేసి ఓకే అట్లా మీరు ఇప్పుడు లాస్ట్